Okay, thank you, Ben. And that's a bit of a big introduction, isn't it? I hope I live up to it. Yeah, the Moulster and Griffiths nursing model. So some time ago, I worked with some colleagues on developing a nursing model for learning disability nursing. And I was asked if I'd come and talk about it at this conference. Very timely, because we've done some work on it recently to update it. But Deborah and Ruth did a really good job of introducing my slides because we haven't collaborated about what should be in our presentations, but I think this says something about the fact that we are all on the same page. And I'm sure if all of you had been asked to do a presentation that was about learning disability nursing today, you would have probably started off with the same sorts of things about context. So where are we today? What's happening in the world of learning disabilities? And there are lots of things going on that are impacting on us. And I've put a few of those things. You know, we know there's a national shortage. We know there's a difficulty in recruiting enough students because of the bursary and other issues. We know that there's a reduction in learning disability nurse leadership, and that there's lots of reasons for that. And we know that that means there's been a 55% reduction in consultant nurse posts, 44% salaries of matron, 44% of reduction in modern matron posts, and 45% reduction in nurse manager posts. That's actually quite scary, because if you don't have leadership, it's very difficult for people to make sure they're always doing the right thing. There's other things going on, and we talked about Twitter earlier, but the increased media attention is being enhanced by some of the new ways of communication that we have. Social media is a brilliant, brilliant thing. It brings you information literally as it happens. So as the inquest is going on, we know what's happening. It's there on social media immediately. But it also means there's information about all sorts of things in a much broader public arena than there ever was before. So like Deborah talked about some of the incidents in the past in hospitals, but generally speaking, the extent that people knew about that would be generally people that knew about hospitals, families, people involved in them, and that would be as far as it would go. Now, if there's a public outcry about something, everybody knows about it. So it's in the general arena, all these inquiries. That doesn't actually help us as learning disability nurses, really, because you can be tarred with the same brush. On the flip side of that, loads of positive stuff about learning disability nursing is getting out to other people now, which didn't happen before. We've got new things going on like nurse associate roles and apprenticeship, and we've got changing needs. I'm going to really whiz through this because I think Ruth touched on it a lot. And we have this increasing learning disabled population at both ends of the scale. Babies living into adulthood with really complex and multiple profound needs, and people living longer with the same diseases of old age as the rest of us. And learning disability nurses are unique. We are an essential, highly skilled resource for improving health outcomes for people with learning disabilities, and there's not enough of us. And I just want to read out what I wrote down, because it's almost like we were on the same script, Deborah. It says, I wrote this down. It's important that nurses are enabled to focus on the things they are trained to do. We don't have the luxury of being able to do everything anymore. If there are less of us, we need to be focused and clear about what and why we are doing something, so we can clearly describe it to others. We need to be able to evaluate and reflect, so we can always practice in the best interest of the person we care for. And I sort of feel, I only want to read it out to show we're all thinking the same way. This graphic was done by Pen Mendoka, who's in the other hall doing graphic facilitation today. And it was done a couple of years ago at a conference in the trust where I was working at the time. And we had a focus group of people with learning disabilities and families. And we asked them to tell us what they thought about learning disability nurses. This presentation is available, will be available to you all afterwards. But you can see that they could not think, we tried really hard to get them to say something negative. They could not say anything negative. The families and people with learning disabilities really do value what we do and how we support and help them. And I think we must always keep sight of that when we're thinking about where we're going. The people we care for, they really want what we do. There's somebody who did say we were eccentric. I can't think why they thought that. I was in the room at the time. So why should we, as learning disability nurses, use a nursing model and framework? And again, people have talked today about the importance of us as clinicians, as nurses that treat, as nurses who intervene. And when the model was first developed, I was working in a service that hadn't had any clinical leadership for a very long time, and the nurses had just been left to get on with it. Most of them have been qualified a long time, and they qualified at a time where we didn't really use much evidence base. We just were taught what to do and we did it. I've been around even longer than Deborah. So there's something about what could we do to change that, to help those nurses to be consistent, to make sure that if you were referred to our service, you could expect a consistent approach from the nurses that were caring for you. And there's quite a lot of stuff. You can go and read about nursing models. There's quite a lot of quite old stuff about why nursing models are a good idea. But what they do is they do actually help you focus on really important things. And there's nothing in that list there that you wouldn't expect to be in a list of what you do as nurses, I'd like to think. They're kind of conceptual tools or frameworks that you can hang your practice on. So you might be out there doing all sorts of things, but if you've got a model or framework to hang it on, it makes it much easier to describe, to actually say what you do. There is evidence to suggest there is a clear relationship between using a model of care and achieving outcomes. And there's information around about reduced mortality rate, very important. We're talking about LEADER later on, people have mentioned it earlier. Using a model of care might actually help us to reduce that premature mortality. And obviously you can read all the rest of this, but it does actually help us. And somebody talked, Deborah, I think you talked about our tribe. And I think we are a tribe, aren't we? Learning disability nurses, we're small but powerful. And I think using a nursing model really helps us to think about what matters, what's important, what's important to learning disability nurses as nurses. This is another of Pen's graphics because she did another conference with me in the background there. But so the model, when we created the model, we wanted to make sure that all the nurses working in the service I worked in at the time, wherever they worked, whether they worked in the community or in an inpatient setting, I was working with nurses working in the prison and in the acute trust, wherever they worked, that they would have a basis for their nursing practice that they could all use. What it does is it ensures a sort of shared vision for what learning disability nursing practice is, that we can explore and explain to people we support and those we're accountable to. You know, everybody's measuring us now. Either financially or in other ways, we're having to say to people, this is the value we bring. And by using the nursing models, nurses can ensure that people, wherever they lived or whatever they were doing, actually got the same standard of person-centred care and evidence-based care. And it benefits nurses because it allows people to, and encourages people to work in a very systematic way, and it encourages reflective practice. So it ensures that we not only use the evidence base, we use the experience and the intuition and the knowledge of the nurse, that knowledge that you bring to nursing that you can't quite quantify. It captures that as well. We looked at loads of models and we thought, this is a bit's good and this bit's good, but what we found was, and you will all have done this as nurses probably, taken a bit of one model and a bit of another and used it to work for you. So we said, okay, let's try and bring something together. So we liked a bit of various different models. We really liked Aldridge's Ecology of Health model, but there were some bits missing from a nursing perspective. And we wanted to have a reflective element. So we thought, well, let's just use Gibbs because most nurses know about Gibbs. It's not about, it's not a nursing model, it's a model of reflection. But it was like, if nurses know about Gibbs, it will make it easier for them to feel comfortable to use it. Actually, within the model, you can use whatever reflective approach you want. You don't have to use Gibbs, but it's just what we used. And we found McCormack and McCantz's person-centred framework, which is not a nursing framework at all, very helpful as well in developing the model. And Orem, and obviously we thought, let's base this around the nursing process because, again, nurses know what the nursing process is, they understand it, they work that way already. So it was about saying, let's not make this model difficult for people to use. And it supports this whole sort of, you know, oh, I won't read that out, biosocial, spiritual, all that stuff. So it's an eclectic model. It brings in other people's ideas. We're not reinventing the wheel. Let's use the wheel and make it work more efficiently for us. That's what we were trying to do. Let's bring the wheel and make it better. Let's put better tyres on it and let's pump it up a bit and give it a bit of oomph and make it work for learning disability nurses. What we wanted to do was to make sure that the care that we delivered is evidence-based, because I think if you go back to the sort of time when I qualified and trained, we didn't really use evidence like we do today. And I think actually getting people to think about evidence and recognising evidence changes, things change. What was good practice, again, I feel like I'm repeating what Ruth said, things change. So you need to be contemporary, you need to be looking at what's the latest evidence for the thing you're going to do. Is what you always did a good idea? And I always use the salt in baths example. When I trained, you put salt in people's baths if they had a wound or a pressure area or anything like that, you put salt in the bath. And then later on, there was some very good research that pointed out that actually, whilst it is an antiseptic, it hurts. And really and truthfully, there's a lot better antiseptics you can use that don't hurt. So why would you stick salt in people's bath? But I guarantee you, you'll still find a few nurses around that stick salt in. I'm sorry if anybody here puts salt in the bath. But the evidence suggests that's not a good thing to do to people. Especially if people don't want to get in the bath in the first place, it's not going to help, is it? So we wanted to make sure it was evidence-based. We wanted it to be person-centred. We wanted it to pick up on the whole idea that person-centred nursing care is important and should be the way we work. This isn't just about working individually. It's about thinking about what matters to the person. What do they want, Deborah? Not just what do we think they need. And we wanted it to be reflective. We wanted it to demonstrate that the nurse has thought about what matters to the person, has taken on board the evidence and their own experience in creating and formulating their nursing care plans. And then those of you who know me will know I've been very involved in developing the HEF, the Health Qualities Framework. And the reason I got involved was because I was working on this at the time and I was looking for an outcome measure. So that's how I ended up doing the HEF, because we were like, well, we haven't got anything suitable. So we wanted something in the model which was about saying how you're going to measure so you can show people that the nurse has made a difference, especially because we work in multi-professional teams. And it's like, well, who made the difference? The nurse, the next door neighbour who said hello this morning, the consultant psychiatrist or the social worker, or, you know, the fact that it's raining today. It's kind of like those things are all part of making it very difficult for us to describe how we make a difference. So this is sort of what it's all about. It's all about making sure that the effect of people's person-centred plans on their personal health and well-being and their personal aspirations, dreams and wishes and plans for the future are taken on board when we actually deliver our nursing care, and that we take on board their emotions and well-being, the way they communicate and how they need us to communicate to them, and the way that their behaviour impacts on them and others, the sort of lifestyle that they have. What's happened in the past is so important to what you're doing now, and people's history really does impact on their health and their ability to be well. We're not always terribly good at looking at the past. We might look at the past in relation to a particular issue. So you're working with someone around some sort of behaviours that we find challenging. What we often look at is what's the history of behaviours we find challenging. What we don't look at is where they lived, who they lived with, who were the important people in their lives, what things made them happy, not necessarily at that moment in time. So also there's something about people's knowledge and understanding, their physical health. And I've left till last to talk about impact of nursing, because there is something about who we are and what we bring. What's your personality like? Is that going to impact on your ability to work with this person well? You know, we can't alter the fact that no matter how hard we try, we don't like everybody. We don't, do we? Does everybody like everybody? You don't. Now, how do you protect the person you're caring for and their family from the fact that maybe you don't take to them? How do you protect that when you're providing care? It really will have an impact on the outcome. Our knowledge, what do we know? Do we know enough? Are there other things we need to know so that we can really work effectively with somebody, and what we're able to do, our skills, and our attitude to the particular type of care that we're providing? Not everybody's suited to everything. Some people like Sally are brilliant in an acute sector, and somebody else will say, gosh, I couldn't possibly do that. I'd much rather work in this community team, or in an inpatient assessment and treatment service. Or we're all different, and that's great, because that makes us what we are, this family of learning disability nurses. And how good we are at reflecting on what we're doing and responding to our reflection, and being honest with ourselves about when something works well and when it doesn't, and what we might have done to make that happen. What did we do that might have actually impacted on that outcome? So the model tries to pick all that up. We use the nursing process, like I say, and so the idea is that you start off by thinking about what how to be person-centred. You think about the evidence that underpins the areas of practice that you're going to intervene with. You think about all the information you've gathered and what that means about what you might do. I worked with a lady once and she couldn't bear it if you did that. She would go mad, scream, shout, literally, break things if you did that, because she'd had her life where people did that to her because she spoke very loudly and she was quite deaf. And to her, going shh actually meant you're going to be horrible to me. And a lot of people do, I mean, how many people think that's a negative behaviour to go shh? It's not particularly negative, it's quite a gentle thing to do, isn't it? But for her, it was a really significant thing. And to be able to reflect on the way something like that might impact on somebody and how it might have affected your relationship with that lady and your ability to work with her is so important. And I think quite often what we do is we kind of get pulled into, well, that was really difficult. How did we manage that and what should we do differently next time? And not actually think back to what it was that made her respond in the way that she did and what did we do to make it worse. Right. One of the things we did with the model was to create some tools that go within it, and we created quite a detailed assessment process which includes assessment of physical health, mental health, social health, all those things, including blood pressure, checking people's, including those sort of things, blood pressure and blood tests, actually asking the GP to do blood tests and looking at the results, urine tests, those sort of things. All of that is in the health check. And what we did was we then put into the assessment a checklist of things that the nurse might need to know, because in learning disability nursing, depending on where you worked as a student, you may not have had experience of all those things. You may not know how to measure a BMI if you've never done it. So there's a sort of information bit that goes alongside it that you can dip into to find the extra information to help you carry out that assessment. So there's some physical checks as well as the sort of questions that we often ask people. What it does is I think one of the reasons for that is that the service I was working in was a multidisciplinary, multi-agency team, and they'd got rid of the nursing assessment when the team became joined, and they had one team assessment. But what that did was it took out all the nursing stuff. So they asked lots of really useful stuff, but actually missed out some really key nursing things. And so we said, let's bring plain back nursing and actually think about what do we need to know as nurses so we can deliver the right care. What it does is it highlights the person's nursing needs and informs your care plan. Now, actually, you can use the model and use a different assessment. You don't have to use the one we put in there, but we've created one to make it easier for people. And it's based on the evidence based around effective nursing assessment, and we use loads and loads of other assessment tools that we found, none of which had a name on. We couldn't find anything allocated to it. They were all anonymous because people have been reinventing that wheel again, hadn't they? So, so we've created one now, but obviously, if you do create something, put your name on it. We also use the knowledge and experience and ideas of all the people that were working in that team in Haringey in London at the time. Now, we've just updated it about 3 or 4 months ago, and there's now an Excel version of it. It's not because I'm the Excel queen, because I'm really rubbish at anything to do with IT. It's because one of my colleagues is very good at that. And what it does now, it's much easier. It's a much smaller document to use because you can go into the drop-down boxes and find information. So those of you who are really good at IT and technical things will totally understand why it's a much better form. There is still a Word version for those people who don't want to use that. But it means, so for example, if you wanted to find that additional information for you to actually work out what you're doing, you can dip into the drop-down boxes. We should be working within the context of current thinking and policy so that we make sure we do give the best care. And we should be applying our nursing skills and knowledge in a structured way that's person-centred. Ruth, I've got a quote from you here. It's accidental. And then this is something that should be so familiar to you. One of the things we found was that people actually didn't know much about care planning. You know, there's this sort of idea that we all know how to do a care plan and there's a sort of standard approach, but actually people really didn't know very much about how to write a proper care plan. And what they had was like a list of tasks, which I didn't think was a care plan. Anybody can have a list of tasks, open the door, turn on the light. That's not a care plan, you know. And so I apologise, there's a few arrows that have moved on that. But basically, the idea is that you start off with your care plan, you think about what's the purpose of it, and you talk to the person if you can, or their advocate, and work together on what that might be. Then you set objectives, taking into account what that person wants and what matters to them, not just what you want to achieve. You then look at what the evidence is to support any sort of intervention you might make around that. And this is the step that people miss out, always. And then once you've looked at the evidence, you decide, well, who's going to implement the plan and what are the resources needed? And if you go back to my thing about what impact do you have, if you really haven't taken to this person, are you the best person to implement the care plan? Is it better to talk to your colleagues and think about whether someone else might be more comfortable doing that, and can you work together jointly? There are things you could do differently. Set your timescales, at least for when you're going to measure what you've done and how you've achieved it. And then identify what you want the person-centred outcomes to be, not just what the expected health outcomes might be, and do that with the person or their advocate. So what do they want from your intervention as a nurse? I feel you said that earlier. So, implement your plan, deliver your evidence-based intervention or treatment, and then review your plan and your objectives and any actions you've taken. Measure your achievement. Have you achieved any person-centred? Has that person got person-centred outcomes that they want? Has it changed something for them? And have you achieved any health outcomes that you were trying to achieve together? And you measure that with the person. You don't go off in an office and sit down and say, oh, look, I did this. You talk to the person about it. Then reflect on that process and the implementation and decide what to do next. Nothing complicated about that. It's following a nursing process. Now, we know that traditionally it's been incredibly difficult to measure learning disability or intellectual disability nursing outcomes. And it's been a thing we've struggled with. Ben locked 4 of us into a hotel room once and made us stay there till we came up with an idea. And that's how the HEF was born. So he says we're friends, but you know, what else can you do? And we came out with a HEF. And as you probably know, I hope most of you have seen it. And if you haven't, go and look it up. It's an outcome measure. More importantly, it's not just an outcome measure. What it does do is it gives you something that helps you to decide on your priorities of care. What's the most urgent thing that you need to focus on? Because 9 times out of 10, it won't be what the person was referred to you for. I'm going to talk about that in a case study in a second. So this is a case study. This is a photograph I got off the internet of some random chap. So it's not the person concerned, and I've changed some key information in it to protect the guy's identity, including the names of the nurse and other people involved in him. So it's all, I've anonymised it, so you can't identify him. The age is about right, but most of it's... so Dave is 54, and he's got moderate learning disabilities and is on the autistic spectrum. He moved into a residential home from the community about 10 years ago after his dad died. And his mum and brother are in regular contact and wanting to be part of Dave's life. About a year ago, Dave had surgery for a bladder problem and was fitted with an indwelling catheter. And as you know, indwelling catheters very high risk for infection and discomfort and pain and all those things. Probably you could ask whether he should have had an indwelling catheter, but that's another issue. Since then, he's regularly suffered with infections requiring courses of antibiotic treatment. Now, he finds personal care quite difficult, and he can be quite verbally abusive, and on occasions he's also hit out at staff caring for him. This resulted in being prescribed antipsychotic medication, as well as extra sedation whenever he needed the catheter changing. So you can imagine what sort of state poor Dave was in. Recently, the consultant psychiatrist and a community learning disability nurse were working with the staff in the home to try to reduce the antipsychotic medication because he was on the psychiatrist's caseload. So they started to do a bit of work with him, but they hadn't got involved with him in any other way at the point of this referral. They had a theory, the nurse and the consultant, that actually the change in his behaviour might be caused by pain, caused by infection, and nothing whatsoever to do with him having sort of behavioural issues. The home manager, who wasn't a nurse, didn't understand that pain or illness might be at the heart of his problems, and she didn't want the medication changed under any circumstances. The medication was to stay, and she was doing everything she could to keep the medication. And it was being reduced, and while it was being reduced, he became very unsettled and quite challenging to the staff, especially when receiving personal care. As a result of that, they raised the ante and contacted psychiatric services and asked for somebody to come out and assess him, the GP. And 2 doctors from the mental health service who had no experience of learning disabilities went out to assess him, and the home manager told them he was mentally unwell and described his complex behaviours, and it resulted in section papers being completed for him. This is a true story. with a few changes to help protect him. So they wanted him admitted into an inpatient service urgently. Luckily for him, there wasn't anywhere for him to go that night, so he just had to stay at home. So they'd done the detection papers, but, you know, luckily for him, he couldn't go. He had to stay at home. Well, it was lucky, because he wasn't mentally ill, Ben. It shows, fantastic system. This wasn't that long ago, it's fairly recent. So the following morning, the Specialist Learning Disability Service was contacted by the Mental Health Service, and they said, can you organise for him to be admitted to a mental health unit, please? That was what the referral was for. And Alison, the community matron from the intensive support team, and Elle, the nurse who'd been involved in the antipsychotic medication review, decided they'd go out and see him. And, Elle's the psychiatrist and Janet was the community nurse. And so Janet was told what was happening, but Elle and Alison went to see him. Alison spoke to the staff and to Dave's mum and his brother. And Alison and Janet completed a HEF profile. And then they organised an emergency meeting with the GP and the social worker, and Elle contacted the mental health colleague for an update. So using the framework for him, Janet completed a person-centred screen at this point. Now, that hadn't been done before because the referral she'd had was purely working in the psychiatric clinic, so she hadn't been working with him. It's a bit complicated, but anyway. And they identified his person-centred goals with him and his family. Now, because he was so distressed, it was quite difficult, but they worked out based on a best guess, which is sometimes what we have to do, isn't it? That what was important. And even though it was an emergency situation, they were able to identify that he would want to be at home with his family if he could be. That he loved going out with friends for a picnic in the past. So the likelihood was that if he could, he would want to go for a picnic. He'd been on holiday and had a lovely time before, so they thought probably it would be something as a person-centred goal when he's well and feeling well he'd want to do. To not have any pain. And to be able to choose the people who support him and the people who help him, bear in mind how difficult he finds personal care. And to choose when to get up and when to have his personal care. Okay, we're all right, we are. So this is his initial HEF profile. Now, if you haven't seen one before, the bigger this shape, the worse it is. And as you can see, he was scoring very highly around communication, genetic and biological condition. But the behaviour was actually quite low. Now, the referral had come in for behaviour, but it was actually quite a low score. And that says if you were prioritising, you wouldn't be focusing on the behaviour, you'd be focusing on those other two things. So the initial plan was they put an emergency care plan in place to assess his pain levels and to treat him for the infection and work closely with him and his family to establish the best way to support him. Alison and Janet created a pain picture and a life book and a health action plan and a hospital passport for him. And the GP started him on a pain patch containing morphine. And then Alison, Elle and Janet worked very closely with the care provider to identify the help and support they needed to enable him to stay at home. And the home manager was changed by the organisation following some discussions about whether or not it was actually the right place for her to be working. And as a result, a different approach to his care was implemented. So, following the introduction of the emergency plan, Alison and Janet reflected on all the information they had gathered through the person-centred screen, the nursing assessment and the HEF profile. And then Janet developed a full nursing care plan and easy read care plan using pictures of people and objects of reference that Dave could identify with. As well as the person-centred goals, Janet set some desired health outcomes, and Janet used evidence to inform the best nursing interventions. In particular, she drew on evidence related to working with people on the autism spectrum, effective communication, pain assessment and management, partnership and multi-agency working, health action planning, and the use of hospital passports. References and evidence were included in the professional care plan to inform anyone providing the nursing care. So if you picked up his care plan tomorrow, you would know what you were supposed to do, why you were supposed to do it, and where to find out more information about it. So now he's following the interventions, he's much happier. He started going out and socialising, and his relationship with his family's improved. His care staff are working with him in a different way. His behaviour's really changed. No recent incidents of physical aggression. He's still living in the home, hasn't ever been admitted to hospital, and he's settled and content. And his HEF profile shows a significant reduction of the impact of the health inequalities, which put him at significant risk of serious illness. So you can see, I haven't put the whole thing in there, but you can see that the red is how it is now. And I've just put social and genetic on there so you can see the difference. So the blue boxes are how he assessed in the first place, and red is after intervention. And as a nurse, to be able to demonstrate that you've made that difference is really important. So that goes in his file. Janet then evaluated. She reviewed his care and his care plan, reflected on the person-centred outcomes and the health outcomes. She used the model. Using the model helped her to formulate an effective person-centred evidence-based care plan. She had the confidence in the approaches she used because they were based on evidence and the things that mattered to him. So she was really confident about what she was doing. She used a reflection within her personal supervision so she could discuss effective and less effective nursing approaches and any personal professional development needs. And she was able to use the reflection of her personal contribution to Dave's care as a reflective study for her NMC revalidation. I just have a little, clever isn't it that sparkles. I didn't make it sparkle, I just found it and it sparkled. I just want to say thank you to a few people. Obviously the people from Haringey nursing team were very involved when we first started the framework. And to Tom Griffiths, who suddenly just asked me who he was, so I thought I should say Tom was a nurse working in the team at the time who worked with me and did some of the research and was involved in the early days of the model. And I feel without Tom we wouldn't have what we have. So, and then there's a number of other people that also helped along the way. There's loads more. And just to say, the graphics were done by Pen Mondoka, who, if you find her, her graphics are brilliant. And if you want to know a bit more about the model, you can contact me. But this is like the plug, isn't it? There is a book. There is a book. There's a book being written about it. It's sort of in process, and it should be out. You can find it on Amazon now, but you can't buy it yet because we haven't finished it. But it will be out early next year. It'll be wonderful. There are people in the room who are contributing to it, I might point out, if they ever get around to writing their chapter. I'm not going to look, just in case. I'm not going to go through all these references now because there's loads of them, but again, if you want to see some of the references, you can find them when you look at this later. And I just wanted to finish with Pen's graphic. We need more nurses because they take the pressure off other nurses, therapists, doctors and others, helping them understand learning disability. They work well with community and advocacy groups. We can be more open with them about the quality of our care. This is from people with learning disabilities, and I think they do a good job. And at that point, I will shut up.